Hi, this is a video on how to organise a one-stop clinic for ovarian referrals, an urgent diagnostic clinic, ovary. My name's Suzanne Johnson and I'm a gynaecologist in Southampton. NHS England recently published this paper about implementing a timed gynecological cancer diagnostic pathway, and in it they suggest that an urgent ultrasound should be possible for patients referred on an ovarian pathway. If it isn't done in primary care, then it needs to be done by a specialist practitioner based on IOTA standards, and that's the important bit. In our clinic, we set up such a clinic 10 years ago, and it works a bit like this. The patient would see the GP with vague symptoms, usually like persistent distension or bloating, loss of appetite, early satiety, pelvic or abdominal pain, and increased urinary frequency or urgency. And the GP would examine, and if they felt there was something in the pelvis, they would refer to the 2-week wait gynae-oncology clinic. If the examination was normal, they might sometimes do a pelvic ultrasound instead. But during the pandemic, many patients were not examined, and we certainly don't insist on it. NICE would suggest a CA-125 as a primary investigation, and if it was normal, to repeat in 6 weeks if the patient was still symptomatic, and if it was raised, to arrange a pelvic ultrasound. The problem with the CA-125 is it's only raised in half of stage 1 ovarian cancer, and it can easily be raised in premenopausal women due to menstruation, endometriosis, and in postmenopausal women, let's say chest infection, cardiac disease, etc. So we don't ask for a CA-125 prior to referral, it just causes delays. And many GPs now will refer any abnormality on ultrasound to gynae-oncology as well. So our urgent diagnostic clinic, ovary, we take all the ovary referrals for the Friday oncology clinic. We pass them through this clinic first, the diagnostic clinic first. So they would come to the diagnostic clinic on a Wednesday and then be seen in the Friday gynae-oncology clinic. And this clinic is staffed by a gynaecologist, that would be me, and I do a transvaginal pelvic ultrasound and possibly transabdominal views too if they're appropriate. So in this clinic, I would see 6 patients, about 40 minutes each, and I do this once a week. I would take a history, do a transvaginal ultrasound and transabdominal if it's necessary, save the images to PACS, report the scan in CRIS, and calculate the risk of malignancy using IOTA easy descriptors, simple rules, and ADNEX. Then I'd make a management plan either to triage the patient out to benign gynecology or to keep the patient in the 2-week wait pathway, discuss the results with the patient, and request an urgent CT chest abdo-pelvis and a CA-125 if it hadn't been done. I would ask to have the patient enroll in a research study if they're willing, if this is appropriate, and email the 2-week wait MDT team for a plan regarding triage. So how do you use the IOTA systems? There are many longer videos which I would recommend you to watch, but basically I use easy descriptors to see if the mass looks benign or malignant, and that accounts for half of all pelvic masses. If they're not applicable, I would go for simple rules. Is the mass benign or malignant? And now that would apply to about 75% of all adnexal masses. If the simple rules are uncertain, like in those cases, I would calculate the ADNEX score next, and if I wanted, then I would use the ADNEX score to look which category they're in, and then in the ORADS chart it would give me suggested management on the right. For fail-safe, I would email the 2-week wait patient pathway coordinator and copy in the gynae-oncology nurse specialists, giving them the patient name and hospital number, the age, the scan findings, the CA-125 level, and then say what it was on simple rules, what the ADNEX risk of malignancy was, and what my subjective opinion is it benign, uncertain, or malignant, and suggest likely histology. And then either triage out to see a named benign gynecology in the next 4 weeks, or for the patient to attend the Friday 2-week wait clinic, having arranged a CA-125 and a CT. Or if the patient DNA'd, I would record that, and the pathway coordinator would take it from there. We also audit these clinics. I set it up 10 years ago now, and we see about 6 patients a week, and every few years we audit this, and so far it's been a very safe thing to do. We triage out nearly half of all patients from the 2-week wait service into benign gynecology now, and this is one of the papers that we wrote about that. So how do you set up such a clinic? We haven't ever had any special funding, and you end up saving money for sure, because you arrange fewer CT scans and have fewer unnecessary laparoscopies. It's safe to do because we've been using published IOTA risk of malignancy models, but training is extremely important so that you have been trained in this. I've also trained 2 other sonologists in my unit. They're senior gynecologists. They already had the RCOG intermediate gynecology ultrasound qualification, and we did a lot of hands-on training. Or you could, in such a clinic, set it up with a radiologist with a special interest in gynae ultrasound, or a sonographer specializing in gynae ultrasound, and we're planning to do that this autumn. Further improvements to the pathway, we're arranging for a certain number of reserved slots to have a CT on the same day as the diagnostic scan clinic, and our oncology nurse specialist will help with this, as there's quite a few bits and pieces that need to be arranged, which I wouldn't have time to do myself in the clinic. And of course, we always need to train more sonologists and sonographers, and then we'd be able to have more of these very quick diagnostic clinics. You have to be very careful to triage your referrals by an admin team, and I don't advise this at all. If the scan is done by someone else, you don't know if they've been scanned in the IOTA method of performing the ultrasound, and I would say you always need to repeat the scan by somebody who is an IOTA trained sonologist or radiologist or sonographer, because if the previous sonographer didn't see an aspect of the lesion, then they won't record it in the report, and if they're not trained in IOTA language, then their adnex calculations or somebody else's adnex calculations based on their report may be very misleading. For instance, in the IOTA definition, what is a solid component? And for instance, the white ball of a dermoid is not solid. If you count it as solid, the adnex score will be high. The number of locules is not something that people ordinarily count. What is a papillation and how many of them there are? And then the definitions of shadowing and ascites. It's very important that whoever does the scan has been trained in IOTA. So this is absolutely crucial, training in IOTA ultrasound. And the IOTA group themselves have a website, iotagroup.org, and you can attend their courses and do online learning. I have a lot of videos on this subject at gynaecologyultrasound.com, and mentorship is something that you could consider. Also very important, once you've set up this clinic, is to allow the sonographer enough time, so to start with only 4 patients a clinic, and you can always build it up to 6 later on. And this means that using IOTA terminology and risk prediction models is that all of these will no longer be called complex, because complex is not a word that we recognize, but you'll be able to say whether it's benign or malignant, and with some more practice give an idea of histology as well. Thank you.